All right, good evening, everyone. My name is Megan Richardson. I am the Associate Director for Sam Houston State University's Office of Health Promotion, and I am the chair of our Elevate Committee, which is our Healthy Campus Initiative. On behalf of Elevate, I'd like to thank you all for joining us for today's presentation, which is entitled Mythbusters: The Truth About 20 Infectious Diseases on College Campuses. So, before we begin today's presentation, I'd like to cover several ground rules with you all. So, please ensure that your microphone is muted. You can be on camera if you so choose, but you do not have to feel obligated to do so. If you have a question for our presenter that you would like to ask, please drop that in our chat feature. And there will be a survey at the end of the presentation. If you complete that survey, you will be entered into a drawing to win an Elevate prize pack. So we do encourage you to stick around until the end to complete that survey. So I'm going to go ahead and introduce today's speaker. Dr. Manis is an assistant professor with Sam Houston's College of Osteopathic. I cannot speak today. Osteopathic medicine. Say that a couple times twice. All right. She directs the clinical medicine 3 and rural and underserved medicine courses and lectures in several other courses, including systems in neuroscience and behavior, cardiovascular and respiratory, and HEENT and immunology. Dr. Manis has ongoing educational research projects in the culture of medicine, medical professionalism, and the development of virtual escape rooms for clinical and interprofessional education delivery. She received her bachelor's degree in biology from Texas A&M at College Station, her master's degree in biological sciences at the University of Houston Clear Lake, and her medical degree at the University of Texas Medical Branch at Galveston. She has held many positions in academic, clinical, and administrative medicine, including the Director of Health Services at Stephen F. Austin State University. So I'm going to go ahead and turn it over to Dr. Manis. Thank you.
Thank you so much, Megan. I appreciate your help also with setting this whole thing up. And it's been great to work with you on the Elevate Steering Committee. I was just smiling as you read that. As I type it, it's a lot shorter than when someone reads it. But, given my age, I think I'm allowed to have worked a bunch of places and earned a bunch of degrees. And as far as saying College of Osteopathic Medicine, that's why we say COM. It's hard to say. Okay, well, it's nice to see everybody that was able to join us. I'm going to go ahead and do a slide share. And I believe y'all will let me know. Not happy with that one. Let me try this one, y'all. There we go. Okay, are y'all okay on the screen? Okay, great. I have a presenter view that I was trying to pull up, so thank you very much. Okay.
It is currently on the presenter view. The way you had it the first time, we did see it as the regular, just the slide by itself. So the way we see it now is the presenter view. Either way is fine. Whatever works.
I'll go ahead and leave the presenter view because I don't have anything secret in there.
Okay.
So y'all can read my notes and see what I was thinking anyway as I develop these slides. Okay, so Mythbusters, 20 myths about infections on college campuses busted. I would have done this talk even if I hadn't been Director of Health Services at SFA, but that additional experience really taught me a lot about some of the misconceptions that our American public has, not just people in college, but it allowed me to see a lot of different ages through the years of my practices and realize that everybody shares that. I think I was hoping at some point that so much access to media and online information would be helpful. And I think overall it really has, But there's also things out there, which y'all know, that are probably not accurate. So I think overall, there's still a lot of things that we can clarify. And I hope you find some myths in these 20 slides that I can bust for you. I am doing this at Megan Richardson's invitation, because we are on the Elevate Campus Wellness Initiative Steering Committee, and actually Megan runs those meetings and does a beautiful job. So anyway, that's how I know her, and that's how I got to do this talk tonight. So let's move to our next slide. Yes, that's me. Now, resources. Okay. When it comes to infections and other health issues, please avail yourself of the excellent SHSU Student Health Center. I'm not going to name names, SFA, but you know, I've been other places, and our health center here is fantastic. I haven't met everyone that works. So I think when I first came to work a couple of years ago, I tried to meet people over there, and that's usually where we have our Elevate Steering Committee meetings. So I have met another few, but everyone I've met has been wonderful, and the reputation is excellent. You even have access to a lab, to pharmacy. I mean, it's just wonderful. You've got a lot of excellent providers, including a specialist in gynecology, nurse practitioners. I was just very impressed with the whole operation. So please, if you have any questions, issues, concerns about your health, they are an excellent resource. Now, a lot of you, of course, had private healthcare providers before you came to the university. So we're one of those actually out in the community in Conroe. The College of Osteopathic Medicine faculty, who are clinicians, who are physicians, work in the clinic. I work there 2 days a week and teach and do research the rest of my days. So if there's anybody that wants to avail themselves of that clinic, please do. We are not the same as the health center. The health center has separate funding, and they provide services for students, and that's their focus. SHU Physicians Clinic is not. We're like a private office anywhere else you would go. So that would be the difference, but we'd always be happy to see you. Now, if you're going to consult Dr. Google, which is fine. As I said, I have 2 suggestions. Great websites, WebMD and the Mayo Clinic. They have the most up-to-date, accurate, easy to understand information. I give those resources out to my patients all the time. So if you're gonna look around the internet, please check those 2 while you're at it. Okay, so why did I choose these 20? Well, there are probably many more, but these 20 to me were the most common diseases. And that's not just according to me and my personal experience, that's according to the American College Health Association that keeps statistics from universities and colleges around the United States as far as health and wellness, disease and infection. So I'm going to keep the gross picks to a minimum. You know, I have 2 adult sons. One, shout out Eric Manis, is a senior here. He's a Bearcat. He is probably the biggest reason I'm here. I asked him and his younger brother, who is in grad school right now at UT Austin. Okay, so I'm giving this talk, right? It's not to my medical students, it's to undergraduate students and perhaps others in the audience from Sam Houston. What are the health myths? And they just, of course, looked at me like, you know, oh, mom. And I pushed them, right? And they said, well, if you have any gross picks, that would probably be really interesting to people. So I do have a few, but not many. So, you know, go to somewhere else like Dr. Pimple Popper, which I cannot watch personally, if you want to see that kind of stuff. But I just want to warn you, I do have a couple. They're not bad. So we're not going to talk about bed bugs, head lice, pubic lice, or scabies. Why do I say that? Well, that's to point out those are infestations. So not everything that happens to our bodies is an infection. An infection is actually defined as a state produced by the establishment of one or more pathogenic agents. Those are agents that cause illness, like bacteria, protozoa, or viruses. If they're on or in your body and they cause disease or discomfort or some health condition, then that's an infection. So I also wanted to tell you, I was telling you why I came up with the myths, most common, etc. The comments I have to introduce each one, these are actual comments or questions from actual patients. I have been doing this a long time. I have interacted with, I can't tell you how many, tens of thousands, I guess, of patients over the years, and loved almost every minute of that. But I was able to pick up a lot of actual quotes. So without further ado, our first myth: colleges make students get meningitis vaccinations for the money. Well, not really true. Meningitis can be a very serious illness. and it's caused by the bacteria Neisseria meningitidis. And it is spread with direct contact, and that's through oral secretions. Fortunately, this bacteria is not very contagious. So even though there may be spreading of oral secretions, there's not a lot of meningitis infection. However, it is so terrible and can be, in fact, fatal. Actually, the state of Texas requires students who come to university to get a meningitis vaccine. Not to scare anyone, let's be honest, vaccines are not, never are, 100% effective. Viruses and bacteria that the vaccines may be fighting against and trying to arm your body to fight against cannot keep up with some of the viral and bacterial mutations that those organisms undergo. So although the vaccine was there and it worked in studies, when it's out in the community being used in thousands and tens of thousands of people, there may still be a case. So like I said, not to scare you, but you might as well reduce your risk by getting a vaccine. And I believe almost everybody I'm talking to has had one. So your risks, actually young age as far as being a young adult and living in group settings. This isn't just colleges, this is also our military barracks, military installations, or travel. And I know people go on volunteer humanitarian or mission trips to other countries. Sub-Saharan Africa is a place where there's a lot of meningitis. It's called the meningitis belt, unfortunately. So there would be some reasons that you might be at increased risk at a time or else or another. Alarm symptoms. If a patient or if a student has severe fever, we're talking 102, 103 or above, terrible headache, stiff neck, not just ouch, you know, I did something, tweak my neck, but literally have difficulty moving their neck. And another key sometimes is confusion. That person really needs immediate medical assistance. So this is what it looks like in the brain. It has those cute little diplococci, they're called, but they may be cute, but they are mean and deadly. This slide is to remind me, here's the little tiny bitty little diplococci, but those are inside a epithelial cell from a urethra, and that's a genitourinary tract cell. There was an outbreak of what they call sexually transmitted infections in 2017 from Neisseria meningitidis. So that's also to remind you, there are a lot of these bacteria that find new homes. That's part of their mutation too. This is not officially characterized as a STI, sexually transmitted infection at this point, but it may be in the future. Okay, myth number 2, only kids get pink eye. Well, not true, or it wouldn't be a myth and I wouldn't be talking to you about it. Conjunctivitis is the term for infection or inflammation of the conjunctiva, and that's the clear membrane that goes around your eyeball and the inside of both of your eyelids. So if that membrane is infected with a bacteria or a virus, then you will have conjunctivitis or pink eye. It is spread from direct or indirect contact with eye drainage. So that means if you had viral conjunctivitis, say, and you slept on your pillowcase and then went about your business and went back to the pillowcase, slept on the same pillowcase, even though those secretions were dried, you could actually give yourself the viral conjunctivitis again. So washing and drying towels and pillowcases when you have this infection, avoiding sharing anything like makeup, never contact lenses. If you have pink eye, you would want to, if you wear eye makeup, get rid of all of that and replace it, because this is extremely contagious. There's even been cases where people are not like touching their eye, then touching another person who touches their eye. They even will touch a surface and another person will touch that surface. And that's what I mean by indirect contact. So this is very, very contagious. Is it dangerous? Really not usually. The danger to it is if you think you have pink eye and you really have something else, like a bacterial conjunctivitis that needs antibiotic treatment. Herpes virus is not the viral conjunctivitis we're talking about. Herpes virus can cause conjunctivitis, and it can be a very severe problem that can even lead to blindness. So if you have pink eye or red eye or drainage from your eye, Okay, if it's clear drainage, it's probably fine. But if you have eye pain or a vision change, not just blurry vision that you can fix by rubbing your eye, but actually blurred vision, those are alarm symptoms you need care for immediately. And another reminder about contact lenses, anyone who doesn't take care of their contacts well puts themselves at risk for bacterial or viral conjunctivitis. So follow your optometrist or ophthalmologist recommendations on the lens care. And this is what it looks like. You've probably either had it or known somebody that's had it. I've never seen elementary school teachers or school nurses freak out as much. I guess head lice would be number one, and then pink eye would be number two. They're both very contagious, but fortunately not usually very dangerous. So I also hear the same thing about ear infections. Well, kids get those, or I used to get those when I was a kid. This can't be an ear infection. There's something in my ear, is actually what patients have told me. So actually not true. You can get middle ear infection no matter your age. It's spread through bacteria that you breathe in. So there are bacteria coming in through your nose, right? Those bacteria, they may like to live in your nose and may cause you no problem. However, sometimes they're normal bacteria that get into abnormal places. So if you have a problem like allergies, actually Megan and I were discussing that a little earlier, and a lot of us have allergies, that swells the inside of all of that tissue from your nose, your sinuses, and there are tubes that drain the fluid from behind your eardrums to the back of your nose. Well, if you have an allergy that's swollen the back of your nose, that tube that drains that little opening is blocked. And so that fluid that's supposed to be draining, so even if bacteria are in there, they drain out, they can't. So that fluid backs up behind the eardrum, already has that bacteria in it, warm, wet, has nutrients. Oh gosh, the bacteria go crazy. So that's the way that we usually get those. We come into contact with someone who's sick. That is not necessarily going to make us sick. Has to be something else, typically like nasal allergies. What would be alarm symptoms if you have an earache? First of all, if it really does hurt, go see somebody. There may be something in there, but you may have a middle ear infection. Alarm symptoms, that fluid can build up to such a high pressure that it could bust your eardrum. And that's not a good thing. You'll see blood and pus from your ear, and you won't be able to hear very well, if at all, out of that ear. So will it kill you? Probably not. Is it very serious in that it can affect your hearing if it ruptures your tympanic membrane or your eardrum and that doesn't grow back or is repaired properly? Then yeah, it can be serious. That's a lovely picture. Can you see my pointer on the screen? Yes.
Yes, we can.
So, thank you. So I'm pointing to this down here is pus. So this is what a physician would see when they look in your ear with the otoscope, that light they shine in your ear. And these are little actual bones that help transmit the sound waves so you can hear. And this tympanic membrane is very thin. You see this part almost looks like kind of cellophane, wax paper. It's kind of got that look to it. But down here, that's actually pus from an infection. So this is not a good thing. We don't want to see this. So I've had other patients tell me, when I've diagnosed them with swimmer's ear, it can't be swimmer's ear. I never went swimming. Well, actually, swimmer's ear is a fungal infection, and fungus like Candida albicans can cause that. Again, these little critters love somewhere that's moist and somewhere that's warm. So if you have water that typically always carries fungus, that's a normal thing in our environment. Get it in your ear and then it can't drain properly, especially when there's been trauma to your ear canal, like with a Q-tip, then that's when we end up getting an external otitis or an external ear infection. What would be an alarm symptom there? This is actually what it would look like. This is a fairly severe case, not the worst. This is the nasty from the fungal infection. What would be alarm symptoms would be if the surrounding tissue, the ear, was actually swollen and red. That would be a problem. That would mean that this infection has spread past the canal, just the epithelial or normally lined cells, and has gotten to deeper layers. Underneath, in the back of your ear, you can feel that part of your skull where there's tissue back there called mastoid that infections like this can spread to. Very rare to occur, but I would want to include that as an alarm symptom. So I've also heard strep throat is no big deal. I think that's because so many people will say when they have a sore throat, oh, I've got strep throat, or I must have strep. You know, strep throat is a particular type of infection. It's caused by Streptococcus pyogenes. That bacteria is also called group A strep. It's in a group with others. And it causes a particular type of infection. It is spread, like I was explaining about the bacteria that come in to cause that middle ear infection. Same deal. You breathe in, and this is part of your respiratory system, actually, your throat, because that air comes in through your mouth and down into your lungs. So that's how the bacteria travel. Some people actually carry this bacteria, but it doesn't cause illness. Most people, when they happen upon this bacteria, it does make them sick. Maybe not like the picture I'm going to show you in a sec, but causing sore throat and swelling, usually of tonsils and tissue around tonsils. The deal with strep, though, strep throat, true strep throat, is if it's untreated, it actually can lead to problems with heart and kidneys that can be very severe, even leading to failure. Does that happen typically? Does not typically happen. That is not a common occurrence. However, we're pretty vigilant about wanting to treat anything that could be a strep throat. So it's a good idea if you have a bad sore throat, one that doesn't go away in a day, and especially if it's causing even some fever, you ought to have it checked out. If, however, you're unable to swallow, like unable, it's not just uncomfortable, you are unable to swallow, like saliva is coming from the other direction, that's a problem. That means that tissue is so swollen, nothing's getting through, including air eventually. So if there's trouble breathing, those are emergencies. I have seen that maybe 4 times in my career. So not common, but obviously if it occurs, extremely dangerous. This is a nasty picture. This is a strep pharyngitis. And these back here are tonsils, and those are full of pus. The top is full of pus, and there's some red over here. So that's a bad strep throat, but that's what they look like. This picture, though, you're going to maybe see again, and that will illustrate how important it is to get an accurate diagnosis of strep. It can be done with a very simple test, like a long Q-tip looking swab, goes at the back of the throat, not painful, and it takes a sample, and there's a very quick and easy, fairly inexpensive test that can be done to see whether you have strep throat, strep pharyngitis, or some other type of sore throat. So I've heard this over. I got this cold from going outside when it was cold and rainy. You know, that makes sense. But many studies have been done to look at that, and they actually have not proven that to be true. Cold viruses like cold weather. So people tend to get cold, the common cold, more when it's cold outside, but that's not a requirement. People have colds all year round. The common cold is caused by multiple viruses, like lots, including one that we know now all too much about. Coronavirus is a family of viruses. So the coronavirus that causes the common cold has very little to do with the coronavirus that is SARS-CoV-2. So just seeing coronavirus, don't let that bother you. But it is one of the big families that cause colds. So spread obviously is respiratory, but it can be indirect. In other words, cough on your hand, shake hands with someone else, they touch their nose, boom. That is the most common way to spread colds. It's not coughing or sneezing on somebody, although that can also do it. It's shaking hands. And you know that this is one reason why I included coronavirus in the list of viruses that can cause common colds. I think the rate of common colds is going to go down because we've changed our social habits to the point where we don't shake hands anymore. So we'll see. Point of research for the future. Really, the risk is being around someone who's sick and not being careful to wash your hands and not touch your face until you have. Really no big alarm symptoms for something that's truly a common cold. However, you can get a secondary infection from bacteria. So the same bacteria that might cause a middle ear infection might cause a sinus infection. Same source, you're breathing it in. This is a CT scan, and it's like you looked at me cut this way. You're going to get a picture right there. We call it a slice. And this, of course, is brain, and you see the nice little skull outlined. Bone is white. These are orbits, and in the middle there, eyeballs. These are teeth. This is mouth. So what are all these curlicue things through there? That's actually your nose. That's actually part of what makes up your nasal cavity. This part of your body is responsible for warming and humidifying the air that comes in so your lungs can handle it better for oxygen exchange. It's also responsible for blocking large particles, you know, hair in your nose does that, flies don't get too far, but it also is responsible for an immune response. So that's the first place your body fights anything that you've breathed, any virus or bacteria you've breathed in. So that's nasal cavity, but those are sinus cavities. You know, that's a big pocket of air. And, you know, if that wasn't air, if there wasn't so much air in your skull would be too heavy to hold up if it was all bone. So these pockets of air also allow us to have a vocal quality. Singers need those sinuses, for instance. But you notice this one is all black. So black in this film is air. Black in this film is air, but look how little there is. This is actually swollen sinus lining, and that's from an infection. So when I looked up a good, you know, picture of sinus infection, because it's an inside, hard to find one, you know, that really shows it, I thought this one might. This shows you that there's something in there that doesn't belong. Sinus infections are not a common complication from common cold, but they happen enough to where if you have a cold, you really do want to make sure it clears. Colds can last up to 2 weeks, common colds. Certainly if symptoms aren't getting better, or if they got better and then got worse again, those are signs that you may have a secondary sinus infection from all that swelling and blockage of drainage that the virus from the common cold did. So only way to catch mono is from kissing. You know, it is termed the kissing disease. So that's not a lie. Yes, you can get it from kissing. Oral secretion sharing is how mononucleosis, that infection, is passed from human to human. That's what I term contagion. But you don't have to kiss the person. It's oral secretions. When we talk, have you ever seen this on TV? Like a singer or someone who's talking on film and they have a light behind them and you see all these particles. When we talk, tiny little droplets spread, some of us more than others, but anyway. And so when that happens and you're in contact with that for a prolonged period of time, like 15, 20 minutes even, you can get mono that way. So not only household contacts like family members, roommates. So be aware of that. If someone that you're around a lot has a bad sore throat and you get one, then again, especially if you have fever, you're going to want to check that out and make sure you get treated. An alarm symptom when someone has mononucleosis, you know, mono can last for weeks. And one of the things it does, it has certain cells, white blood cells in the body that are cleared by the spleen to a large degree during that infection. And so the spleen, which sits under your rib cage on the left side, organ you need, some people can live without it. There are people without spleens, but it's an organ you need for a good immune system because it clears out those old white blood cells after they've done their job. Well, there's so many that the spleen is enlarged. And so people who are diagnosed with mononucleosis are advised to avoid contact sports, avoid anything that could be a blow, even with the ribs protecting it, to the spleen. So that is a problem if there's abdominal pain, especially after trauma when you've been diagnosed with mononucleosis. This looks a little bit like that other picture, right? And I put that in there because the sore throat can be a lot of different things. Virus, yes, it could be strep or it could be mono. And there's a rapid test called a monospot, a test that can be done in the physician's office. It can be done in the student health center to make sure that mono is not what's causing a sore throat. So please, please don't say this in front of me ever. You can catch the flu from the flu shot. Let me explain where that came from. I'm old enough to remember that 80s, probably 70s, I think it was 70s, when the flu shots were given, the only way they knew how to make a flu shot, like what to give us into our bodies to let our bodies form antibodies to fight off an influenza, a flu infection, was to actually use the influenza virus. Then they went to a killed virus where they had actual viruses, killed them, I think it was with heat, and used those for the vaccine. Well, they don't do that anymore. That's been decades since they've done that. But when they did, guess what? You could get the flu from getting a flu shot. So someone my age or older really may say that and say that from experience. However, for decades now, vaccines, influenza vaccine is made from parts, from proteins. The proteins that they have studied enough to know are the things that alert our immune system to start producing antibodies and other chemicals to try to fight off an infection with influenza. So it's not physically possible to get influenza from the current influenza vaccine. And if you ever hear of an actual case, I would have to say, where did they pull that vaccine from? Because that's just not the way they're made anymore. So if that's anything that keeps anybody from getting the vaccine, please put that out of your mind. I have gotten the influenza vaccine since it came out. So I've had, I don't know how many doses, because the data behind its utility and its decreasing risk, not only for me, but the people around me, are really excellent. So that's my little spiel on flu shots. Okay, only old people get pneumonia. I was told that by a person who was in his 20s that I was diagnosing with pneumonia. Not true. There are people, there's a type of pneumonia group of bacteria cause called community acquired pneumonia. That means someone who's pretty healthy otherwise comes down with a pneumonia. These are caused by respiratory spread of actually multiple bacteria. Several different types of bacteria can cause this. So what are your risks? Well, certainly being around someone, but a lot of these bacteria may live in the environment anyway. So it's perhaps something where your immune system is not quite up to fighting the fight, or maybe you have an underlying lung disease, and asthma even counts for this. So alarm symptoms, if you have difficulty breathing for any reason, for any time other than a minute, you really need to get immediate help. Pneumonia can also cause chest pain, and it of course can cause fever and a cough, typically one that's yucky. You're coughing stuff up. Your lungs are trying to clear all this stuff that not just bacteria make, but that your body is making to try to fight off and get rid of that bacteria. Let me go back to that. Now, pneumonia is more serious as far as mortality, as far as who dies from it. It is more serious in older people, and that's why the pneumonia vaccine is recommended for people over 65. So I've had patients tell me when they had diarrhea, when they had vomiting, this must be food poisoning. It never really hits our mind very much that that could be a virus. Acute gastroenteritis is a fairly common infection. Now, it's got a nasty little spread though, and it's called, in medical terms, I guess, oral fecal. That means that someone who's had certain viral or bacterial agents in their bodies, whether it caused them an infection or not, did not wash their hands when they should have. So that's your risk. And this is true for the person getting the gastroenteritis. It's also true for when you eat something that someone else has prepared at their house, at a restaurant, etc. So acute gastroenteritis is out there, and it's usually not severe or serious. However, it can be. And if you have nonstop vomiting or nonstop diarrhea or abdominal pain, other than a little cramping, that's really something to get checked out. There are things that mimic acute gastroenteritis, like food poisoning. Some people get acute gastroenteritis type symptoms when they're having appendicitis, at the beginning at least. There can be other causes. So anytime there's significant abdominal pain, it's a time to go visit a health professional. So I can't get hepatitis. I've been vaccinated. I diagnosed hepatitis C in a patient, and this was the response. What they had done, they had actually been vaccinated for hepatitis A and B, but not for hepatitis C. Hepatitis A is caused by what we were just talking about, acute gastroenteritis from a fecal oral route, but B and C are not. They're passed other ways. Bodily fluids is how those are transmitted. There is not currently a vaccine for hepatitis C. And it can be a very serious infection. It's not as widespread, so apparently we're able to fight it off fairly easily. So those of us who may have been exposed are not necessarily infected, but it's still a very dangerous infection, and one to be aware of. I've heard this so many times. Only gay men get HIV. Because not that I've diagnosed that many cases, thank goodness, with HIV, that many patients with HIV, but I've been told this by people I encourage to get an HIV test. So they actually have a belief that if they belong to certain groups or they have certain sexual practices and not other sexual practices, that there's no way they can get HIV. Totally not true. totally not true. Can't say much more about that. Anyone can get HIV. It is spread through bodily fluids. What is the biggest risk for HIV? High risk behaviors. Anything that shares blood, sharing needles in particular, because we would like to think that everyone that happens in the medical arena, everything is cleared of HIV. Blood donations, test any blood that's donated is tested for HIV and has been for 20 years now. No, probably more like 18 years now. Anything that we use in the medical environment has been sanitized with every virus, including HIV, removed. So typically the sharing blood we're talking about is from sharing needles during illicit drug use. Can also be during certain sexual practices that abrade tissue, and that can cause sharing of blood and bodily fluids. Genital fluids is mainly the way HIV is spread. HIV is still out there. People have HIV and show no signs for quite a while, typically. The immune response takes a while to break down, and the HIV takes a while to replicate to the extent that it breaks it down. What are alarm symptoms? What might mean someone has HIV? Frequent infections can be. That certainly doesn't mean that you have a bunch of colds this year that you have HIV, not at all. But one of the first signs that people can have is recurrent infections, and typically not the minor ones like common cold, typically more severe infections, but they get them more often than you would expect. Also lymph node swelling. That's the other symptom that usually people come into the office with that would make their healthcare provider suspect. Neither of those things are common though, as I say. So the best way to prevent the spread of HIV is to get yourself tested if you have had any high-risk behaviors. And high-risk behaviors involve typically certain types of sexual practices, especially without condoms. HIV is stopped by proper condom use. Not using a condom does increase your risk. And that's what I mean. One of the things I mean by high risk behaviors. As part of sexually transmitted infection screening, HIV is typically offered at least at a minimum once a year. Many times it's offered more frequently, and definitely if patients come into the office and say, I may have exposed myself or been exposed to an STI. I'd like to get tested. That's the battery, and that includes HIV. There are some others, though, that are included, that are included in our suspicion, but are not included in any blood test that we can tell you that that's what you got. I've diagnosed herpes, genital herpes, many more times than I would like. Like 0 would be nice, but this infection is very easily spread. It's also very tricky because it is not spread. The spread of herpes is not blocked necessarily by proper condom use. So there can be a herpes infection in genital tissue without real obvious signs, even to the person themselves. And contact of one person's skin with that infected person's skin, that is enough to cause spread of that infection. So there are a lot of people who have herpes infections that used condoms and thought they were, taking proper precautions. Herpes is tricky that way. And it's actually a fairly common infection now. There are other types of herpes simplex virus, that subtypes that do not infect genital tissue, but infect lips, like the area around lips. We call that fever blister. So there are subtypes that attack different types of mucosa or mucous membranes. But this is a tricky little guy. And I think the best advice that I've read about trying to reduce your risk is know your partner, know your partner's health, and discuss these things. That means, thinking about what you're doing at the time and having a clear enough mind to think about what you're doing. Is that 100% foolproof? No, but it will reduce your risk. If there's pain with an ulceration or something that looks like there's an opening in the skin, herpes ulcers usually don't have fluid that's copious, like something that you'll really see a lot. There is enough to cause infection though. I did want to point out, I see my notes now. My partner wore a condom. Okay, that doesn't necessarily help, or it was my first time. And this actually, I've diagnosed people that have told me that. And that's really sad. So please take the precautions that you can to prevent that. And another myth along those lines, they can treat, insert STI here. So there's a lot of them that I listed down there. So it's no big deal. It's true. There are treatments for syphilis, gonorrhea, chlamydia, trichomonas, bacterial vaginosis. It's true. The trick to them is getting them diagnosed. The spread is bodily fluids, genital bodily fluids typically, although gonorrhea and chlamydia can infect other mucosa, such as in the throat or rectum. And risk, proper condom use works to prevent these infections. The key there is proper, and there's a lot of good literature, and I bet and I didn't ask them, but I bet the Student Health Center we used to at SFA has a documentation, what am I trying to say, like a handout on the proper way to use a condom. It doesn't work unless it's used properly. The problem with, yeah, they can treat it, but it's no big deal. The damage that these infections, syphilis, gonorrhea, and chlamydia particularly, trichomonas and bacterial vaginosis, not so much. Those first three, the damage they can do before they're diagnosed and before they're treated can be extensive and lead to sterility. It can cause scarring in parts of the reproductive system that prevent being able to have children. If you're a man or a woman, either way, it can cause this. So it is serious. There's also pelvic inflammatory disease that can be fatal if it's not diagnosed in time. If there are symptoms like a discharge, any discharge from anywhere that you are not used to having, you should get checked out. And also these can be associated, especially pelvic inflammatory disease, with low abdominal or pelvic pain. So if there's a question, why worry? And I would say that to my patients, why worry? Just go in and get a test. Let's make sure that you're protected, you're treated. Let's make sure your partners are protected. Anyway, it's a simple thing to do. It's much simpler in practice, I think, than patients have in their minds before they go through the process. This is something that any healthcare provider is happy to do, because we can help prevent a lot of misery and a lot of health complications if we just do the test and treat when necessary. I've got this rash. I must be allergic to something. Okay. There are a lot of skin rashes, and the worst one, I believe, unless it's associated with some other condition, is MRSA, MRSA, methicillin-resistant Staphylococcus aureus. This, they used to talk about, athletes got a lot because it was easily spread in gyms. One of the outbreaks I had in a small community I worked in years ago was at a church camp. Anywhere your skin, unprotected, like unclothed, like the lower part of your leg, for instance, your skin is touching something that someone else may have had this infection fluid from. Like if they had an ulceration, a sore, an abscess on their leg, left, hour later you come along and sit there and that got onto your leg and you have a microscopic opening, that's a potential for an infection, for that transmission. So it's an indirect spread. That person doesn't have to touch you with the wound to spread that infection. Indirect contact. Painful rash, abscess. I'm going to show you a yucky picture. That's a yucky abscess. This is just a large area where the bacteria has formed an infected little home, little cave, and this is the discharge. So it's terrible. And you see how far from the actual infected spot this infection has spread into this person's tissue. So this is fairly easy to pick up. If you've got a rash that is not acting like a rash should, like it hurts, or it's swelling, it's starting to get red, that's spreading, you need that checked. I'm too old for acne. Oh, y'all, I wish that were true. There's a bacteria that tends to cause this. But that bacteria lives on your skin. It's already there. So why would some people get acne and some people not? Well, if there's an altered environment to your skin, and this is mostly hormonal, although there are hereditary influences too. So time of life, going through certain age groups, which is typically adolescence, but it can extend past that. They actually have a term, adult acne, meaning it goes beyond adolescence. So certain hormone influences and certain just things about a person's body, typically not what they eat, typically not what they put on their skin, typically not, how they cleanse, etc. Those are not typically associated with whether a person has acne or not at college age. So if there are cosmetic concerns, and definitely those are valid in certain types of acne, abscess or infected mass. So that abscess I showed you, if you have a little something that looks like that on your face, you probably need some treatment. It could be this bacteria, but it could be another one that this bacteria kind of opened the door for. So if you have big, red, swollen, painful, anything, go see your healthcare provider and get that diagnosed and treated. Shower shoes are stupid. Okay, this is one of my favorite ones. And this one was actually told to me by my youngest son as I was sending him off to college. He attended UCLA. So we packed everything we thought a Texas boy might need in California, LA in particular. And shower shoes were something that his mother purchased for him. And he had the most disgusted look on his face as he tossed them out of his backpack and went, "There's no way I am bringing these." Okay, smart boy, bye. Yes, it took about 4 months for him to get back on the phone. "Mom, my feet are killing me. They're burning, they're itching. I've got the scaly stuff between my toes." "Oh, really? I wonder why." Indirect contact with tinea pedis is the reason. Apparently, none of the people at his door were wearing shower shoes. This stuff is pretty hardy. It can live in shower, any area, and it loves groups. It loves anywhere you're congregating where there's moisture on the floor, they're going to like. So swimmers can get this sometimes even. They're in the chlorine, yeah, but then they're in the shower and people are walking around and it's hot. Okay, the tinea pedis love it. So indirect contact, contagion, yeah, it has to be passed to you, but it can stay on surfaces a long time. And the problem could be secondary bacterial infection. So anything, again, red, warm, swollen, painful, especially if it's got pus coming out of it, that's not supposed to be there. Tinea pedis can cause, that's a pretty severe tinea pedis, but certainly not a bacterial superinfection or secondary infection. But this is a case that hadn't been treated yet. So scaly skin, red, this is going to be uncomfortable. He's still walking, but it's not going to be super comfortable. And the itching may have given way to burning on this. So if any of that goes on, you need to get it checked. Easy to treat though, if you want to try an over-the-counter treatment. Those antifungals that you purchase at the store work very well. You just have to continue to use them. If you have a severe case, there are pills that can be prescribed that'll get rid of it for you, at least until you forget your shower shoes again. So myth 17, I'm healthy so my immune system is too. No, not true. College students get infections at a higher rate typically than they did before they left for college. And things like inadequate nutrition, inadequate rest, we all know what that means, inadequate activity, because you're studying, and increased stress. So those things have to be in place and have to be of a level to make sure that your immune system is functioning properly. So the best thing you can do to avoid any of the infections we talked about, short of those specific reasons, things I gave you that you could do, get your adequate nutrition, rest, activity, and do what you can to manage your stress. Again, the Student Health Center has resources for this. The Student Counseling Center has resources for stress management, and you don't actually have to do more than click on their website, and those are posted. They also provide some resources to other websites you can go. So if you don't feel like this is something you want to go visit somebody for, okay, there's plenty of good information out there, and those 2 resources I gave you, WebMD and Mayo Clinic, are excellent. My symptoms are gone. I can stop my antibiotics. Oh my goodness, please don't. What was that other thing I asked you not to say in front of me? Flu vaccine? This is the other thing. Please don't tell me this. Bacteria love people that say this because they are exposed to the antibiotic just long enough to learn how to mutate and fight it. So stopping your antibiotics before they're done, not a good idea. If your doctor has an antibiotic or such medicine for infection that they say, yes, when the symptoms are gone, you can stop, typically not an antibiotic, maybe another type of medication like a steroid that they're giving you for an infection. So unless you're told otherwise, if the bottle says twice a day for 7 days, finish it. Set your alarm. There's no real excuse for forgetting antibiotics. And they're very important. We look at the time frames to give these medicines to people because of studies. 7 to 10 days, 10 to 14 days. That's meaningful. That's based on a study of a lot of people with that infection. So anyway, enough preaching. Those bacteria are tricky though, and they will mutate. Using antibacterial soap stops infections. I mean, it makes sense, right? But they do not. Studies have shown actually that they do not. They remove bacteria perhaps, but it's not necessarily the bacteria that causes infection. It can be some healthy bacteria that allow other bacteria to swarm. I use antibacterial soap, but I don't depend on it to stop infection. As we learned with the COVID-19 pandemic, it's not just what you're using on your hands when you wash them. I'm not talking about alcohol-based hand rubs. I'm talking about soap and water. It's actually the friction. It's actually the mechanical removal of microorganisms. It's not so much the type of soap you use. If it's labeled as soap, you're going to be okay because it's got a certain like pH and chemical makeup, whether it's got fragrance or whether it has an antibacterial ingredient or not. So that's really the important, is soap and water. It doesn't have to necessarily be antibacterial. That being said, some of the antibacterial soaps are very harsh on skin. And I've had people with kind of an inflammation like a dermatitis from just the soap they're using. I get them to switch to a soap that doesn't have an antibacterial component, and the rash goes away. So some of those ingredients can be harsh depending on your skin sensitivity. So to stop infection, soap and water, almost all of those, not all of them, but almost all of those, soap and water. And I guess I could put soap and water or a condom or proper condom use. And that would really help you towards reducing your risk for infection to almost everything I've talked about tonight. Avoiding contagion. Yeah, stay away from sick people. Okay, we've learned that too, I guess. But do watch what you're doing and who you're doing it with or around. Healthy immune system, we talked about nutrition, rest, exercise, stress reduction. Going to preach that because your body has mechanisms, almost everyone's body has mechanisms in place that help you fight infection and help you recover from infection. But one of the tools your body has is your immune system, and you have to keep it functioning properly. Number 20. Yeah, I'm not going to belabor this point. I'm young, so even if I catch COVID-19, I'll be fine. I'm so sorry to say that that is not always true. I'm happy to say it's usually true. But why take the risk? So please watch your social distance, wear a mask, wash your hands. I know everybody's doing that and we're all so maybe COVID overloaded this time, but honestly, as severe an infection as this has been, it's a pandemic. It's the only one I hope to see in my lifetime. I don't think we can remind ourselves enough about it. So not to belabor the point, there's a lot of excellent COVID-19 information. Student Health Center, SHSU has COVID response team. They have, it's a Restart, I think is the name of the website, where they talk about all the precautions and all the recommendations for COVID-19. So we've got a lot of good information out there. Be aware that it changes constantly. One of our physicians here, Dr. Candace Walkley, is an infectious disease specialist. And she is on the COVID response team, obviously, but she monitors the news from medical sources almost daily. So, and she keeps us informed, but it's amazing to all of us how quickly these things change. It's wonderful how much research is being put in, but remember, this is so new to everyone. As time passes and as we do more research and are able to see what's really going on, then we'll have probably smarter things to say. But right now, these are the 3 things that I would encourage you to do. And that was my talk. I just want to help everyone remember to stay safe. You will not be successful in anything you do in life unless you keep your health. I shouldn't say never. It's very difficult to be successful in most anything you choose to do in life unless you have your health. It's the most precious gift that you have. Nothing replaces it. If you lose your health, nothing will be the same. And dreams are cut short by those kinds of things. So I mean, stay safe in the broad sense. Stay well, mental health, all of those things that put any of us at risk for health problems. Please be aware. We take such good care of certain things of our lives, like my phone. I've got a nice case. I disinfect it. I update it. You know, I do all this great stuff for my little pocket computer. I need to be as vigilant and as responsible, honestly, for my body. I need to make sure that it's well taken care of too. And I'd like you to think about your most precious belonging. And as well as you take care of that, I want you to take care of your body and your mind just as well. And that's what I mean by stay safe. Okay, that was the end of my talk. I have not been paying attention to chat, y'all, because I find that very difficult to do while I'm talking. I'm so sorry. So if there are any questions that you have, you're welcome to unmute or you're welcome to put them in the chat. If there's something I didn't cover, and you'd like me to try to touch on it, I'll be happy to do that too.
Dr. Manis, thank you so much for all of that excellent information. As somebody who is an infectious disease nerd, it was just a perfect for me. Some of these myth busters, I loved it. So it looks like we have a couple of questions in the chat. Before I read those out, I do want to encourage everyone to take our survey. So I dropped the link for that in the chat as well. If you complete that, you will be entered to win an Elevate prize pack. So that's a t-shirt and a water bottle. So just click that link, and maybe I'll put it in here again, just in case anybody missed it. Go ahead and complete that. It's just a couple of questions. Doesn't take long to fill out. But our question from Ellen. So would it be proper to say that STIs are not all treatable today with antibiotic resistance? And how do antibiotic resistance affect the treatment of these infections? Will there become a point where we may run out of options for the treatment of these illnesses?
That's a great question. And actually, it does not happen very often. I think one of the reasons is because usually it's pharmaceutical companies are doing constant research. But it has happened that infection I talked about, MRSA, methicillin resistant Staph aureus. Staph aureus is everywhere. But it was always able to be killed, usually by penicillin. Well, the bacteria mutated to the point where penicillin, and in the lab methicillin, was not able to kill it anymore. What happened was it caused a problem for, actually it was a few years, 3 to 4 years, but research, not only in labs, but also clinical research, the type that the physicians, in my world do, we gather data. So we can find typically another antibiotic that will work. And the same, I would have to hope, maybe not assume, hope would be true for a sexually transmitted infection. Some bacteria and viruses are better at mutating than others. So syphilis, for instance, we've treated we've treated gonorrhea the same way for as long as I've been around. And there hasn't been any mutation. Certain of the chlamydia subtypes, sometimes you have to treat with a different bacteria. Different antibiotic. So it's a great question. I don't know that I have one definitive answer. The odds are that we'll be fine. We'll be able to use the current antibiotics. If the bacteria mutate, we also have a mechanism, at least in our country, but definitely throughout the world, to further investigate and eventually come up with. We even have a treatment for HIV now. So on a cure, I think there's documentation of one patient having completely no virus and it doesn't come back. But everyone else that's taking the antivirals for HIV, they can get down to very little, if no, viral activity. So even something that, historically we were afraid would never be cured, never be treated, is actually being treated now. So I guess I have a bias, but I have a lot of confidence and hope in research and in the intellectual curiosity and American determination to fight things that hurt us. And so far, I think it's been a great job. People have done a great job in this country on that. I hope that answered that. Was that?
Sounded good to me. We have time for one more. So follow up to that is the same for hepatitis C. So is that answer the same for hepatitis C?
Hep C, they're trying to find a treatment. Hep C, those hepatitis viruses they're in the same family, but they act so differently. And hepatitis B, there's a treatment for. And that was just a revelation. Again, another virus that years ago nobody thought we'd ever be rid of, and it killed people, especially when there was other liver damage, like from alcohol use or genetic diseases. It killed people. And now, if it's caught, diagnosed, definitely if people got the vaccination series, but even if people are infected, it's caught early enough, it can be treated. So yeah, hepatitis C, they're constantly working on finding something to treat hepatitis C with, but so far, no. Viruses are so similar in their RNA or DNA to us. It's difficult to find medications that will fight viruses and not fight us. So that's the really tricky part with viruses. That's why they've been so hard to treat and to cure, because they share so much with our cells. So scientists have to find what the difference is and then find an agent to attack just that difference. So hepatitis C has been stubborn. I have not seen anything new on that, though, as far as them getting closer.
All right, so our last question is in regard to allergies caused by COVID-19. So why don't they just give the EpiPen to people to take at home after administering the vaccine as a preventative measure?
Allergies to the COVID vaccine?
Is that the, yes, Dana's, nodding her head. Yes, to the COVID.
That's a good question. Epinephrine, the EpiPen, is only for a certain type of allergic reaction, and it's called anaphylaxis. And it constricts the trachea and the bronchioles. So it closes off your airway. And so epinephrine will help relax those smooth muscles and help your airways open. That is not the typical reaction to the COVID vaccine, or frankly, any vaccine that people have allergies to. The main thing that I've read about the COVID vaccine, now that it's being given more widespread, is local reaction. So that like a redness, a little bit of tenderness, that's not actually an allergy. That's your body's response, but it's not an allergic response. So it's kind of hard to tease out, allergy to the vaccine. They could do allergy testing to the different chemicals in the vaccine and determine if it's really an allergy. They're not going to probably do that. Are you asking because you've heard of someone who had like a severe allergic response to the vaccine, or you've read about that? I wonder why you were asking the question. Make sure my answer's right.
Feel free to unmute, Dana, if you want, or you can answer in the chat. Here you go.
Hi, thank you.
Hi.
Yes, I've heard about the 10 cases, the new cases now on TV, and I'm kind of scheduled for one. My friends are okay. They have no reactions, no problems. But I was just wondering what kind of allergies work, because they're not very specific when they talk about it. They just raise questions, and I don't know if they want to raise awareness or they want to create panic.
Hard to know these days, right?
Right.
There are different allergic responses. And I guess that's what I was trying to explain about the anaphylaxis. That's the most severe, and that's where you use the EpiPen. But that happens immediately. So, you get your vaccine and you go home, you're not going to have anaphylaxis. That's actually why policies in most physicians' offices, after you give an injection of anything, including a vaccine, you ask the patient to wait in your office for 15 to 20 minutes. And that's to make sure that there's not that type of anaphylactic response. Otherwise, allergies can be anything. Skin reaction can be an allergy. You can have respiratory allergies. You can have GI allergies, like people who are gluten sensitive. So there's a lot of different allergic responses that we could be talking about. Your original question, the epinephrine causes extreme side effects, which are worth it if you have anaphylaxis, because if you don't get it, you die. But it's not worth it to prevent a very, very, very low risk of having a mild or even moderate allergic reaction.
Thank you.
Oh, you're welcome. I'm not on the tier to get it yet, but I'm on the list. I will be getting mine. I know not everybody believes that, and I don't try to talk people out of it. I just want to make sure people have all the information that they need to make an informed decision. So I'm glad you're thinking about that one.
I am. I'm just waiting for more of my friends first.
Now, I usually don't like to be the first group that gets any type of medicine, including the vaccine. However, I think it's one of those decisions that you make ideally with your physician. I know that's not always possible. Anything has a risk, and you have to determine if the risk of even a severe allergic reaction to the COVID vaccine is worth the potential for you not getting infected. So, and that's the problem right now. We don't have enough information to make the best decision, I think. That as good a decision, I should say, as we will even in several months. And that's what I was cautioning about earlier. Don't take what I'm saying today and go, well, that's not right, judged by what's going on next year, because things change so quickly. So that's a very difficult decision. I saw in the chat something about code blues. I would assume that was anaphylaxis. I can't imagine what other kind of reaction that would have been. And that's pretty horrifying to hear. The other thing about COVID in general, but definitely COVID vaccine, you know, things happen like we call it anecdotal. So there's anecdotal information. You know, of the 20 people vaccinated at my hospital, you know, so many got this reaction. And that's good information, but there's no good way to put it all together quickly. So the individual hospitals and individual physicians and clinics, et cetera, have to put their information together. Someone has to get it and sort through it. Then it's reviewed, then it's published. So we're like 3 steps away from having all the information that we really need. So I know it's scary. It's a very stressful time in general. Yes, you're welcome. I appreciate y'all's interest on that topic. And I'm not the expert, so I didn't go into it today. But the COVID response team has many experts actually, but Dr. Walkley's on that, and she is a local expert. So
we do have
work part-time in a restaurant. Oh, it's time though, Megan, isn't it?
Yeah, just really quick. So yes, this person, Sequoia, works part-time in a restaurant, and she feels like she's higher risk. Would you agree? And I'm assuming that's in regards to COVID.
Yeah, yes, I would. However, the studies so far have shown that it takes a little more prolonged contact than we thought at first. Mm-hmm. So if you are not in that vicinity with that that person in the restaurant for like 15 minutes, and if so you're within 3 feet for more than 15 minutes, that does increase your risk. I hope in the restaurant world, and I waited many a table in my college days, so I still know that world, as much as you can keep your mask on. You obviously can't ask your patrons to keep their masks on while they're eating, but I personally would probably not visit tables as much as I used to try to help my tips, and I would not linger. So yeah, I agree. I think anyone who has contact with people who are not in their household for any prolonged period of time is at increased risk, yes. So that means you have to be double careful. Wash your hands and don't touch any part of your face until you've done so.
Right.
And good luck.
Definitely. And we are at our time. So again, Dr. Manis, thank you so much for all of that wonderful information. This has just been a great presentation. Thank you to our participants who joined us today. Thank you for sticking with us the entire hour and the questions that you had for us. If you have any additional questions, feel free to email us at elevate@shsu.edu. Either I can respond to that or shoot it off to Dr. Manis. And hopefully if she has time in her busy schedule, she can get back to you as well. So again, thank you all for joining us, and check out our website at shsu.edu/elevate to keep up to date with any upcoming events that we have going on this semester. So stay safe, stay healthy, and we look forward to seeing you all soon. Bye-bye.
Thank you. Bye-bye, y'all.